So we looked at the model of orthopedics, or let's call it musculoskeletal care, MSK care, and we looked at it from a population health perspective, and we said, how can we get evidence-based care within the boundaries or the guardrails of clinical practice guidelines to everybody? So instead of saying, we're surgeons, here we are, come and treat us, we said, no, we'll take care of all your MSK needs. And we developed what they call a non-operative operative model, where the vast majority of people with complaints of orthopedic ailments don't have to see a surgeon because they don't need a surgeon, and they follow evidence-based guidelines. So we developed a technology platform that provided access, care, non-operative medicinal treatment, injections, and then the last resort is injections. And we sort of emulated that model throughout the system at a cost of care affordable to everybody.
Welcome to A&M Healthcare Industry Group's What's Your Moonshot podcast series, where world-class healthcare leaders seek to solve big problems. Listen as we talk to today's health system CEOs about the journey to achieve their moonshots.
We're proud to have Dr. Alex Vaccaro, Chairman and President of Rothman Orthopaedic Institute, with us today. Over the last 3 years, my colleague Steve Boyd and myself have had the pleasure of working with Rothman on various strategic initiatives and growth initiatives. We find Rothman Orthopaedic to be a unique leader in terms of comprehensive musculoskeletal care, delivered with academic excellence and quality that is unparalleled when benchmarked. They're a top 15 orthopedic provider nationally, and they've continued to have an interesting strategy in a world that has shifted from outpatient and ambulatory work, and with a lot of investment capital in creating ortho supergroups, to them remaining independent, extremely financially sound, and partnering with health systems in various geographies to create a coordinated system of care that has proven to drive value and quality for various payers and constituencies within the community. Steve, would you like to make a few comments about how interesting their economic model is relative to other orthopedic supergroups?
Yeah, thank you, Ken. So as Ken said, that unique mix of academic focus, comprehensive care has over the years really driven, I'd call it, outsized and above average margin and operating performance across their practices, to where it allows the physicians to be continually engaged and to continue to grow the full suite of ancillaries and drive outsized performance, to where their leverage remains low and the business generates a significant level of free cash flow to sustain future investment and growth.
I'd like to hand it over to Dr. Larry Kaiser and Dr. David Shulkin to further introduce Dr. Vaccaro and this Moonshot series.
Welcome to A&M's What's Your Moonshot podcast. My name's Larry Kaiser. I'm Managing Director in Alvarez & Marsal's Healthcare Industry Group. I'm here today with my co-host, the Honorable Secretary, Dr. David Shulkin. David, it's my pleasure to welcome Dr. Alex Vaccaro to the podcast. Dr. Vaccaro leads Rothman Orthopaedics, serving as president since 2014. Founded by the late entrepreneur, iconoclast, and pioneer Richard Rothman, who in the earliest days benefited from the largesse of Walter Annenberg, Rothman Orthopaedics is the largest full-service orthopedic practice in the country, with more than 40 offices in 4 states, offering both surgical and non-operative services. The organization also partners with sports teams at all levels to provide treatment to athletes on and off the field. Dr. Vaccaro also serves as the Richard H. Rothman Professor and Chairman of the Department of Orthopedic Surgery, in addition to being Professor of Neurosurgery at the Thomas Jefferson University in Philadelphia. Alex, we're extremely pleased that you've taken time out of your incredibly busy schedule to speak with us today.
Thanks, Larry. Thanks, Dave.
Alex, again, both Larry and I are appreciative. I think, as Larry was saying, I would say that you're probably the busiest guy that's out there in healthcare. You're doing many jobs. You're traveling around the country to share your knowledge, and so it's great to be with you. I think that Rothman has always been a name that's been synonymous with chartering new territory and really creating new models of care. And under your leadership, Rothman has been having a tremendous amount of growth and entering into new markets. Can you tell us a little bit about what the strategy is in terms of continued growth in an area that just seems like it's increasingly getting competitive with other entrants, and also all these disruptors that are out there in the musculoskeletal space?
Well, David, you're the perfect guy to ask that question because you and I have met before. I think the one thing we're lacking in America is access to quality health care. And I have to compliment Obamacare for giving everyone insurance. I don't think it gave everyone access. And I have to compliment your work efforts at the VA and making sure the vets had the appropriate care. So we looked at the model of orthopedics, or let's call it musculoskeletal care, MSK care. And we looked at it from a population health perspective. And we said, how can we get evidence-based care within the boundaries or the guardrails of clinical practice guidelines to everybody? So instead of saying, we're surgeons, here we are, come and treat us, we said, no, we'll take care of all your MSK needs. And we developed what they call a non-operative operative model, where the vast majority of people with complaints of orthopedic ailments don't have to see a surgeon because they don't need a surgeon. And they follow evidence-based guidelines. So we developed a technology platform that provided access, care, non-operative medicinal treatment, injections, and then the last resort is injections. And we sort of emulated that model throughout the system at a cost of care affordable to everybody. And then we partnered with healthcare systems and we said, listen, there's the social determinants of health that we can't affect individually, but collectively we can. And we partnered with Jefferson in the Philadelphia region. We partnered with NYU in the New York region. We partnered with Meridian Healthcare up in Bergen County. We partnered with Advent Health in Florida. And now we're partnering with Swedish Healthcare in Seattle. And we said, listen, help us bring that care to undercapitalized markets where they just don't have the appropriate health care. And that's what we've been able to do over time. So it's been working well, and we're following your footsteps and the footsteps of Larry at Temple Medical School. Larry brought evidence-based medicine to Temple and really transformed the care there at Temple.
So Alex, you and your colleagues have always been committed to the highest quality care, and Rothman is known for quality. In addition to valuing affordability, you and your colleagues initially participated in the CMS BPCI project, but ultimately opted to drop out. If not bundled payments, what's the group doing to keep costs under control? And do you participate in any full risk plans?
Okay, so that's a great question, Larry. So we participated in 54 different bundles. And I thought the BPCI was great, BPCI Advanced was great. But remember, it's designed as a race to the bottom. It doesn't say right patient, right time, right doctor, right place. It says cut costs, cut costs, cut costs, cut costs. You're doing a great job. Now you've cut so much cost. Now you're going to lose money if you participate. So you can't, if you run an efficient model, participate in the government program. It doesn't make any sense. So what it does is it used to say, if you look at your collective geographic area, if you provide care at a cost less than the geographic area, you will save money and we'll have a gain sharing relationship with the provider. It stopped doing that, and it kept on comparing yourself to yourself every year. So if you cut costs by $1, it gave you less than $1 the next year. Cut costs by $1 again, it paid you less and less until you can't cover your expenses. So we're out. But it was a great exercise. It taught us how to look at the things that really increase the cost of care: wasted care, ineffective care, overabundant care. So it allowed us to understand exactly what we were doing right and what we were doing wrong. So that's what we did. Now we're looking at a population per patient per month opportunity, where we look at the MSK spend in, say, Pennsylvania, and we say that it's X amount of millions of dollars. And we say, well, listen, we think there's about 30 to 40% waste there. We will provide that care for 20% less, and we go at risk. And we have at risk contracts right now with various health insurance companies. And we make money at it because we cut our care, and they don't come back and say, well, listen, you've done a great job. We're going to pay less next year. They say, thank you very much for showing us and our other members how to cut care, and they continue to reward the provider. Remember, if I have a person who needs surgery today, I'm going to operate today. I'm not going to churn that patient in a non-operative paradigm that doesn't make any sense. If I have someone who never needs surgery, it doesn't mean eventually if they don't get better, I'm going to give them surgery. It means, no, I'm going to take them out of the healthcare machine and put them in a home maintenance program where they'll get better. So I'm going to say, listen, we know this care is not effective. We're not going to waste our time. And when we looked at, I'll talk about the most controversial topic, stem cells. Like you look at stem cells and you see that it's not approved by the FDA. So orthopedic clinics around the country are saying, okay, come to my clinic. It'll cost $5,000-7,000. We don't do that at the Rothman Institute. We say, listen, we don't mind getting into clinical studies that trial innovative techniques that have not been proven. But if we do look at it, we disclose it to a patient, we take whatever money is received, we reinvest into clinical studies till we see if it's effective. And it's not effective, we stop doing it. And that's the only way to go forward in medicine. We have to innovate, but we have to also understand to study what we do to make sure it's effective.
You know, Alex, that makes so much sense. And I think you just gave our listeners a primer on working with government in some of these programs and the reason why you need to be out in front of the market the way that you are at Rothman. One of the things that you mentioned was that you partner with health systems. And that often seems like a strange bedfellow because the hospitals, of course, are focused largely on their inpatient care. Yet Rothman has a strategy of trying to keep care out of the hospital where it can. And so you've worked on things like same-day spine surgery and same-day arthroplasties, joint replacements. So what percentage of your cases are now being done in ambulatory surgery centers and outside the hospital?
Sure. Today, 70% of all orthopedic care can be done outside of a tertiary quaternary surgical center. If you look at the movement now, 70% of graduates are going to work for a healthcare system, a university, or a hospital system. And I think that is the wrong thing to do. I think independent multi-specialty or single specialty groups are the future in an outpatient setting, and use our hospitals for those that need tertiary care, quaternary care. For an orthopedic surgeon, complicated hip replacements, revision hip replacements, scoliosis surgery, tumor infections, they have to be in a hospital. But simple lumbar decompression, simple discectomies, I'm a spine surgeon, so I'll speak from a spine perspective, can be done as an outpatient. Now, the cost of care is more expensive in a hospital. It doesn't make any sense. So the hospital systems that will survive were those that will JV or partner with independent physicians to work in outside ambulatory surgical centers and incentivize all the stakeholders to invest in outpatient surgery. You can safely do today 70% of all orthopedic procedures outpatient. And we have to study, that's what we have to do. We have to study how we can make sure care is safe as an outpatient. So what I do is I study respiratory problems, chronic coughs. I study the amount of pain medication, how to give people pain relief that's not a narcotic exposure, which decreases the respiratory drive of the patient. And I look at all that, and we can do it. You know, I sort of applauded the government saying we're taking all these cases off the inpatient list, but they did it too quickly, and we didn't study it. We weren't ready for it. And of course, all the private insurances jumped on board. So even though CMS has reversed itself, all the private insurances are demanding that we take our joint arthroplasty patients outpatient. And we're saying, slow down a little bit. We will, once we know it's safe. It's all about patient safety. The center of the universe is the patient, and we have to make sure we respect that.
No, Alex, thanks for that. I think that's a great way to look at things. I did want to follow up with one of the ways that you started out the answer to that last question. And that was that you said, look, 70% of graduates are becoming employees of hospitals and health systems. And you felt that that wasn't necessarily a healthy thing, that you felt that the future is going to be in independent specialty groups. I wonder how you feel about payers who are trying to acquire specialty groups like Rothman. You may be too big to be acquired. And also how you feel about private equity entering into the single specialty market and essentially acquiring physician groups.
Okay, so thank you for making this a controversy podcast, which I love, by the way. So I look at the business model of private equity, insurance companies that want to go vertical in terms of their business model, and I say to myself, well, that's fine and dandy. Are they doing it to decrease the cost of care, or are they doing it to profit? If they're doing it to profit, where does the money come from? It comes off the back of patients. So private, and I call it the 1980 private equity move, where they arbitraged a stock value over 30 years. So they gave a boatload of money to a physician, and the physician was like, wow, this is a lot of money. But then you paid it back, and you had to service your own buy-in by 30% to the debt markets. It didn't make any sense. Now they have the 3 bites of an apple 5-year acquisition plan, private equity. It doesn't make any sense because doctors still have to service that debt. they're not giving you $1 for free. They're giving you $1 so they can make 45% on your dollar each year going forward. And I say that to every orthopedic surgeon. If they're capitalizing you because you can build outpatient ambulatory surgical centers, if you can scale certain things, that makes a lot of sense. But how do they get paid? They get paid by taking the profit off the top. So I'm not a big fan. Now, there's other models where you can bring in outside money. Where can you bring in outside money? From the debt markets, from hospital partners, raising money yourself, or you could use private equity in a different model where they don't own the physician group. They don't ask for a scrape. You know, the term scrape, for the people out there that don't understand, scrape is if I make $1, I joined into a private equity, 30% of the money I make every year, I have to give back to the private equity. That's how they pay for the amount of money they give you up front. If they come up with another model that doesn't scrape from the physician, that profits off of economies of scale because you've dropped the cost of care tremendously, almost like a gain sharing, I could see private equity making money in that way. I could see private equity making money as a general partner in an ambulatory surgical center model where they have carried interest in the general partner performance fee. I could see people making money in that respect, but making money off the backs of a patient, I don't understand. So right now, I'm not a fan of private equity unless the models are changed. So I know that's a complicated answer to a complicated question. Now,
and what about the insurance companies that are acquiring this?
It doesn't make it's such a conflict of interest for the payer to own the provider, because the payer may just say, listen, we're not going to provide those services, so therefore you can't provide those services because I'm paying you your salary. So I really truly believe that the payer has to be separated from the provider. I think there has to be independence for conflict of interest rules, that you have to represent the interests of the patient. Who really looks out for the patient? It's you and I. You're a physician, Larry's a physician, I'm a physician. We truly look out for the best interests of a physician. That doesn't mean all the other stakeholders do not, but we take an oath, the Hippocratic oath, to look out for a patient. So we know, I believe, what's in the best interest of a patient. And in addition to looking out for the best interest, we also have to be frugal. We have to be cost effective. We have to do what Sabella said years ago in CMS, look at the 4 different things that you have to do to make sure healthcare is effective in the future.
So Alex, and you talked a little bit about how the move from inpatient to the outpatient setting in orthopedics, and it's been fueled a lot by some of the tremendous advances in your specialty, not just the minimally invasive approaches, but robotics, as well as improvements in instrumentation and implants. Tell us a little bit how some of these advances have really benefited patient care.
Okay, so the first thing is, you mentioned minimally invasive, which makes sense, but the first thing we needed to do is we needed to make sure that anesthesia was safe. Now we needed to understand those who do well following general anesthesia, those that do well under TIVA and other types of local. And then we had to look at pain management after an invasive procedure. So Larry, they got away from the narcotic exposures. Now we're using cocktails of Celebrex, gabapentin, Tylenol. We're staying away. So we've sort of engineered anesthesia to a point where we're not depressing the respiratory function. So we did that. And then on top of that, we added minimally invasive techniques. So in spinal surgery, we use robots, we use microscopes, and we use navigation. We realized that we could do a surgery through a small port rather than a large incision, which was fantastic. We also understand spinal pathologies better, saying you don't have to do a big scoliosis surgery. You can make a small little correction and improve the quality of life, because we started to use one of the benefits of Obamacare is allowing everyone to use electronic medical records. So now we use big data to identify what patient groups do well, what patient groups do not do well, what patient groups suffer complications. So using registry data that doesn't give us a causation, but associations with adverse outcomes, we've been able to use all that together to come up with paradigms to treat patients more effectively. And that's how we sort of pioneered the outpatient movement in orthopedics, which has been very effective.
You have, in a very short period of time, talked about an incredible array of the landscape in healthcare. But one of the things that we haven't asked you about yet is what you think about all the new technology besides the clinical technology. But in terms of the movement of treating musculoskeletal conditions using telemedicine and using virtual care, virtual physical therapy, virtual post-operative care, remote monitoring, what's your feeling about that? Are we headed in the right direction, or are you concerned that we're going to miss something by not having that direct physical contact?
I am the biggest cheerleader for telemedicine. Right now today, 50% of the people that I do complex spine surgery on, I meet for the first time in the pre-op holding area. I've learned, and we published on it extensively, how to do a validated physical examination over telemedicine And also have learned what patient populations do not do well in telemedicine. Let me give you an example who doesn't do well. As a spine surgeon, you're dealing with someone with a spinal deformity. So you're looking at their imaging studies, you're talking to them, you're looking at the patient. You can't see their three-dimensional balance in space. So I can't perceive that. So there's certain things that we're learning that we can't do by telemedicine. You have to sit with the patient. You have to hold their hand. You have to sort of understand what their needs and wants are. But we can communicate pretty effectively. When I'm speaking to someone in telemedicine, I actually get deeper into the details because I have their reports open. I have their imaging open and I'm talking to them directly. I'm having a direct conversation. I'm not turning my back to them looking at an x-ray. I'm not turning my back dictating into a computer. We've developed great bonds with patients. Now, let me tell you the next benefit of it. This Thursday, I'm the team physician for the Eagles. So I have to fly to, say, Florida to watch us kick Tampa Bay's butt. So that's just on the side. So I will be doing.
Now it's controversial. You know that. We have a national audience.
Now Tom Brady's going to get more aggressive, just like Zeke Elliott killed us in Dallas. But I am now going to be able to do office hours when I'm down in Tampa. I could sit back and do. So now there's no longer, I can only do office hours when I'm in town. I could do office hours between cases, on holidays, when I'm away, and I could look at you like I'm looking at you now. So I think it's great. I love remote monitoring. Now, orthopedic surgeons only use remote monitoring to look at outcomes. So instead of saying you have to come back at 6 weeks, 3 months, 6 months, I get a green, red, and yellow. Green means their function is exactly the way that a person who had that type of procedure should be ambulating. Their stride length is perfect. They don't have to come back for an x-ray. If it turns yellow or red, they have to come back sooner. So I think it's phenomenal. And I'm not talking about glucose monitoring, cardiac rhythms. I'm talking about MSK care. So it is definitely the future. Now, how do we preserve that? We have to go to audio-only telemedicine because our Medicare population doesn't want to look at a video. They don't know how to watch. So I think it's so foolish that Congress hasn't passed that rule to say audio only. You would have to reimburse doctors. Like right now, I don't get paid for tele. I think IBC locally said, we're not paying anymore. I think Aetna said, we're not paying anymore. So I do it for free. So I literally do telemedicine for free. And I only get paid when I do the surgical procedure. And we have to stop the foolishness of insurance companies to say, we're not going to allow you to operate unless you do an in-person physical examination. Because 70% of the time, a broken bone on a telemedicine is a broken bone. You don't have to be in your office to say, oh, by the way, I see the bone sticking out of your skin. So you don't need that either. So it is the future. I love it and I support it 100%.
Well, Alex, first of all, again, thank you for taking the time out of your schedule to speak with us today. But I think what it really comes down to is the Rothman Institute has developed a platform for the care of musculoskeletal disease, if you will, which includes everything, that really is a model that needs to be emulated in major locations. And you're doing that by expanding this platform to areas really across the country. And I think it's been well received because of the fact you bring in incredibly high quality and you do it efficiently and cost effectively. And I think that, to me, is what really is important. And as you have stressed throughout this talk, it is all about the patient and what we can do for the patient, whether it's minimally invasive, whether it's controlling the amount of narcotics that we use, whether it's monitoring the patient at home, telemedicine, all of those things benefit the patient, and that's really what's important.
I agree, Larry, 100%.
I just want to follow up. I think Larry did a great summary, but give us a sense as we close out here, Alex. When you go around and speak to orthopedic surgeons around the country, where is the mindset of the orthopedic surgeon? Are they thinking about this like you, or are they still in a much more traditional point of view about what orthopedic surgery and musculoskeletal care should look like?
So there's many different thought processes. What's going on now, Dave, is a fear that the economics of healthcare is changing so rapidly. Like another deal was made in Congress. So a cost neutrality rule. They're cutting MSK care by 9.6%. They're cutting total joint replacement by 5.4%. We're fighting Congress on these foolish budget neutrality rules. So they're so panicked. And as a result, what do people do when they're panicked and they want to continue to keep their doors open? They make deals with people. They make deals with healthcare systems. They make deals with hospital centers. They make deals with private equity. That's where their mind is now. They should be focusing on what you and I just talked about. How can I provide cost-effective, efficient, safe care to our patient population? And we're not spending enough money investing in the technologies that Larry and I just talked about. We're spending so much time saying we have to advocate to Congress to stop this foolishness that we can continue caring for patients in an economic way. So that's where we are right now. There's a lot of panic, and that's why you're seeing, there was an article that came out 2 days ago that said that 70% of it, private equity is coming in and capitalizing on that fear, which is not the right thing to do today. That is foolish. And I don't think, and I have nothing against joining a university healthcare system, but I think we should think more independently because we could be more innovative. If I work for the man in a healthcare system, I can't be independently innovative because I work for the man and he's telling me what I got to do every day. So I have to be independent. So that's why I think we need to be in the future.
That's great.
Fantastic. Thank you for spending the time with us today.
Right, and I apologize for my cough.
No problem.
All right, guys.
Alex, thank you.
Thank
Good
you.
to see you.
Take care.
Bye-bye.
Bye-bye.
Alvarez and Marcel. Leadership, action, results.
So listening to Dr. Vaccaro, a couple of interesting things come to light from our prior strategy and performance work with Rothman. One, Dr. Vaccaro is the preeminent leader in spine surgery, recognized globally. He is surrounded by, several top-ranked physicians and surgeons within the musculoskeletal care space, and Rothman consistently outperforms and creates tremendous value and quality within the communities that they serve. What we find interesting about Rothman is they've also moved closer to the premium dollar. If you listen to the Dr. Vaccaro, and in moving close to the premium dollar, they've been able to coordinate care between the health system, their offices, their ambulatory surgery centers, and the broader ancillary support services, and thus have shown in several community-based settings that they can provide a better economic, high-quality care base that over time actually saves a good amount of money on the healthcare dollar. We also recognize, from Dr. Vaccaro, that their focus on the patient is exceptional and consistently rank as one of the highest when it comes to patient satisfaction and service delivery. Steve, any other thoughts as you listen to Dr. Vaccaro and kind of how he thinks about Rothman and Rothman's place in the orthopedic community?
Thanks, Ken. I think as you listen to Dr. Vaccaro, it'll be interesting to see the pride that he takes in what the team at Rothman has built, the uniqueness of the model, and the fact that they feel that they are, from both a clinical and an academic perspective, a preeminent ortho group nationally, and can drive improved outcomes. The management services organization there is very strong. Not only does it provide the traditional support services that you would expect from a management services organization, but it also provides a bunch of the clinical know-how and the academic support that's required, and allows the organization the visibility and the support to drive the performance that it expects and generates meaningful cash flow on its own for the organization.